She is a nationally awarded sales leader, a master of go-to-market strategy, definitely a subject matter expert in pharmacy benefits, the brilliant host of a new podcast, Influencers. Her real superpower is connecting people and really facilitating real change. So it is my honor and joy to introduce my friend. She will leave a trail of glitter when she's done with this, the PBM princess, Rachel Strauss.
Thank you. They didn't have me introduce Madeline because I would still be talking about how amazing she is. So hopefully, if that wasn't already evident enough. Thank you so much, Cellphone Health, for bringing me here today. My name is Rachel Strauss. I'm the founder of a company called PBM Princess, which makes a lot of people giggle if you don't know me, and it makes people laugh really hard when they do. I am just leaving about 4 months ago, a 23-year career where I did work for a pharmacy benefit manager, starting in underwriting, moving all the way up through account management, sales, business development. I am also originally from the Midwest. I'll save this as a question. I'm from Detroit, which means I have always been a Lions fan, and you have to understand that has not always been fun. So when you are in your 40s and the Lions, you get to say it, it's like really exciting. So I take that Lion spirit down with me to Houston. I did not jump on the Texans train. I have become an Astros fan, but it's more so because they have a baseball player, Altuve, who's like 5'4". My husband's 5'3", and it gives my son real dreams. So it's very exciting for us, and I did become a baseball fan. So we're here today to talk about GLP-1s. By show of hands, how many people in here have heard of this term GLP-1s? Okay, by same show of hands, if you had to reverse your mind 3 years ago, how many people here have heard of GLP-1s? Okay, so most people don't realize GLP-1s have been out for more than 10 years, and there's a reason why you have heard of them more and more. You know, I think that like GLP-1s are now like the Kardashians of the health insurance world, if you will. They're everywhere. They're really expensive. They seem very glamorous, and they show up in places you wish they sometimes would not. So it's really because they become a phenomenon. They become culture, and they've also, quite honestly, become very expensive. GLP-1s are everywhere. It's become a hot topic, whether you post on LinkedIn, whether you're at a conversation topic at dinner. It is the first time in my 20 plus years of life, my friends kind of understand that I'm not a drug rep anymore because they understand the word PBM relates somehow to Ozempic. And it's like, how do you get Ozempic? And how is it that they're paid for? And it's just really, I mean, I don't want to say it's made our industry cool, but it hasn't made it like not cool. We're talked about now. So when you've said the acronym PBM for more than 2 decades and suddenly people understand what it is, in my space, that is very exciting. So let's talk about, why GLP-1s are here and why they're important to spend almost an hour talking about them, especially in a conference, put on by an organization called Cellphone Health. So, GLP-1s, we're going to get into what they are, but it's very important just as a stat, 1 in 3 Americans, here we can do it right here. How many people here personally know somebody that is on a GLP-1? There you go. So there's our stat. So we're not just talking about drugs, right? We are talking about a true shift in culture. Madeline mentioned in her previous session that so many things in our industry, in life really, are because somebody made a mistake or saw a problem and identified a need for that solution. GLP-1s have created an offshoot of our entire industry. When we go, those of us on the provider side, payer side, when we go to conferences, there could be 10 or 15 companies, all they do is promote GLP-1 solutions. So clearly, we have a problem. So first and foremost, what are GLP-1s? These are medications that were primarily created to treat type 2 diabetes. I have a chart in here that'll show you the timeline, but the first medication that was out was called Byetta. And just quick, if you're ever on one of those quiz shows, the Byetta actually came from the saliva. I think it was either a frog or an amphibian. And what they realized based on this amphibian saliva was that it could help control, in testing labs, insulin. And so Byetta came out, and it was made from this compound of this amphibian saliva. You may want to Google to find out exactly which one it is if you ever are on that quiz show. And what they did is they marketed it for type 2 diabetes. It's sometimes used in type 1 diabetes as a way for especially those who become insulin resistant, but it's not new. What became new is, like many medications, and there was a heart medication, I'm not gonna make anyone raise their hand, but there was a heart medication years ago that also had an interesting side effect for men's health, if you will. While this one, right, we're all laughing, but that is how that medication came to be, and the entire ED class came from a side effect of another medication used to treat something. Well, everybody knows that eventually they realized, oh my goodness, everybody going on one of these medications as they evolved are losing a ton of weight, and in some cases, quickly. And so what you saw was the pharmaceutical companies they probably realized this figure 8 years ago, 6 years ago, formulated it, got extended patents, and then wouldn't you know it, got FDA approval for weight loss. So these are medications, typically Ozempic, Mounjaro, and Wegovy are the most popular. There are other medications in this class. But what's continuing to happen, and for those of you, even on social media, it's hard to figure out what's fact, what's fiction, but the number of things they are finding that these medications have correlated outcomes in is everything from PCOS, addiction even, migraines. I just found some research before I did this proposal. I actually saw it on Instagram.com, if you will. I'm not fact checking that one. But I did find that there are some beliefs that it's actually taking some precursors to Alzheimer's. That is not FDA approved, but if it's out there, there's research being done. And the way pharmaceutical companies work is they repackage and re-promote. And the PBM side in me is here to tell you that financially that's not a good thing, because what that can mean is extended patents, longer for those medications to go generic, and ultimately higher costs that plan sponsors, patients, that our healthcare system will see. And you can see up here the market impact. 2030 sounds so far away. It's not. It's in 4 years, which is, it's mind-blowing that we're almost in September. But $77 billion is what is estimated to be in this class alone in 4 years. So, this is why everybody's starting to freak out. I had a physician recently say to me on a call, there's a lot of us in here, and I've heard it already today, where we say healthcare is broken. Healthcare is not broken. Thank God for healthcare, because we have some of the most incredible technology and advancements in healthcare in the world right here in the United States. What's broken is the strategies around how to pay for it. And that is what we're all here to talk about. Like Madeline said, we identify that there is a problem. And the problem is not necessarily in what's being invented. It's figuring out how to sustain it and to make sure that we have access to it for everybody who needs it. So let's talk about now PBMs and plans, and I don't think I need to get too far into why everybody is panicking. It is because of the cost, and it is because there's no end in sight. It doesn't look like these are going to become generic. You would think with the competition in the space that it would get less expensive. It's almost like they've all kind of gone behind closed doors and said, let's all keep our price tag at least at $1,000 a month. And so, how PBMs have really started to respond is they've either, said it's a problem. They are showing up on all of your top 10 drug reports. And then you're having people say, exclude the class altogether. Well, that's very problematic because, as you recall, I mentioned that these are not just for weight loss. These are medications for type 2 diabetics, many of which have been on them long before Oprah told everybody to get on it. So you have patient populations that need them. You also are seeing, problems because you've got step therapy coming out, and what are the clinical criteria? And so what the industry is beginning to have conversations with is understand what are your goals within this class of medication. Understanding it does make the population that are on it respond favorably, right? Both from the type 2 diabetes, certainly, because it is managing that population. And secondly, as a self-funded employer, what is your take on the company's responsibility for cost as it relates to weight loss? What are those criteria? And you just saw amazing nurses beforehand. This is not where any plan sponsor in this room should be creating your formulary. We don't expect anybody here to go to nursing or medical school. But you should have an idea of, again, scouting your team. How many people are already utilizing them? Do you believe you have a workforce that would want to take weight loss medications? And then you figure out at what cost. So you can see here, just some stats from this past year. We don't have 2025 yet, but in 2024, 25% of employers were currently offering coverage for GLP-1s for weight loss. So this is specific to weight loss right now. And 43% were intending to continue to offer it of the 25. So we're seeing not every employer, but as this conversation, comes to be, I really want to, first and foremost, the first point I want to make is do not consider a strategy a blanket denial of this class. It cannot be a strategy because then you can end up with some very, very sick people who are already on these medications. And because of the cost, they will not most likely, with the average salary of an employee in America today, be able to afford them. And this is where you could get into retention issues, et cetera. So, really what we're finding is this need for strategies. So here are just some, I wanted everyone to have as much data as possible on this class. Here are today, the FDA approved indications. You've got diabetes type 2, you have weight loss, sleep apnea has been approved, and you also have cardiovascular risk that is associated with obesity. So it's decreasing that. So these are the good things. And this is where that $70 billion figure came from, because we now have clinical trials for heart failure, PAD, kidney disease, as I mentioned, Alzheimer's disease, Parkinson's disease, and I forget this one and I apologize, but there's a number of things that are out there. And again, the other target of this is it's also, like I mentioned, on social media. And so, whereas we've always been targeted with advertisements on television, right? I always used to joke, you see the girl running through fields, not getting the allergies, and you go to your doctor and you're like, I need that because I saw that yesterday. Well, now it's all over social media by way of influencers and the ways that we absorb information. And so because of it, you're going to continue to see this demand. So the implications for GLP-1s, in the reach of over, hundreds of millions of people, individuals, there's a lot of good things that are coming from this. You're seeing increased life expectancy. You're seeing more years of healthy life. You're seeing the impact on the economy. That is what we're here talking about, right? But it also can impact the economy in a good way, right? We're extending people's lives. We're extending their ability to come to work. We're putting less pressure on the workforce because people are able to go. And here's our healthcare, right? It's not a mystery. Demand is going to continue for these medications. We're going to see, in a perfect world, if we continue the usage of GLP-1s and they work the way they're supposed to, and nothing comes out 5 years from now that we didn't know about, right? With so many people on them. Well, optimist in me, right? It says we're going to have less chronic issues in the future, right? So there's the potential ROI on the cost of these medications. And ultra long-term, right? We might have an increased life expectancy as a result of this one category of medication. So here's a list of, what has been out. There are no generics today. I just put, and I apologize that it shifted, but you can see the main medications are Byetta, Byndurno, Victoza, Saxenda, Trulicity, Ozempic, Rybelsus, Wegovy, Mounjaro, and Zepbound. I put these here, and again, we'll share these slides with you because those of you who get any form of data, and hopefully you're getting something from whether you're still with a BUCA, if you're self-funded, you're certainly getting this, but this helps you identify what does the GLP-1 impact look like in your group. That's why I wanted to list the medications we're talking about. There are other diabetes medications like Jardiance and glucose, all the insulins. Those are outside of what we're talking about specific to GLP-1. So when you see diabetic medications, you want to make sure that you're talking about it correctly. So as we've talked about, and I'm pounding it on there, they are continuing to grow traction. As I heard it at a conference a couple months ago, which was kind of frightening, but because these medications are shown to work in so many different categories, and now that cardiovascular has entered the mix, there are talks that GLP-1s could be added to PPACA lists. And if you're not familiar with that term, PPACA came as a result of the ACA. And those were medications that are covered on your formulary by law at no copay. Today, there are some statins on there, contraceptives are on there, blood pressure medications are on there. Could you imagine if GLP-1s creeped into that list and now every American offered an employer-sponsored health plan could get them for free? So that's kind of what we're looking at. And the lighting in here is hard, and again, we will share this, but this is the current landscape of where we're at today, and that there's more medications approving patents coming in the next couple years. So this will kind of show you what to look out for. My husband laughed. He said, I'm giving everybody pharmaceutical companies that you should kind of potentially invest in. But I'm like, no, this is not inside trading. But it does show you kind of where things are at, what phase trials are in, et cetera. So in this response, right, PBMs, we talked about it. The first, gut reaction from the self-funded world was, let's just exclude them, right? Part of the beauty of self-funding health plans is that you can control your destiny, right? You as employers, you as brokers, consultants, risk providers in the room, we all work together, right? As I love Madeline's, scout, putting together a team. The gut reaction was, let's just exclude everybody trying to get this for weight loss. That was the first thing I saw, and I see some nodding of the heads. The problem with that is, number one, you have, some employees may not like that. Number two, nobody thought to look at what their medical side covered when they did that. So you had employers say, no, we're not going to cover weight loss medications. But then they had bariatric surgeries covered on the other side. And so it was kind of like a misdirect. And then, which one really is cheaper when you look at complications and the medications that need to sustain it? So the first piece of advice I would give as you are looking at your 2026 renewal, or if you're currently involved in one, take a look at what the messaging is across your entire SPD. What is your approach to taking care of patients? The next piece of advice I can give you is, if you do have a weight loss program or the company has decided to do it, my recommendation is carve it away from your general benefits, because then any dollar amount you put on that program does not have to go towards an out-of-pocket maximum. It's still something you can contribute to. It's still a program the company can sponsor. But then you're not also adding up costs that, also avoid other out-of-pockets from the patients and their other health that the plan is already underwritten for. So that can also help with stop-loss rates. Next is, we see out there that some pharmacy benefit managers are creating their own compound programs. And again, this is where it's becoming a marketplace and understanding what's available out there. Does the company have to cover the medication, through the PBM, or can it be a compound either the PBM's partnered with? They may have their own pharmacy lab creating it. There's the discounts on these compound medications are anywhere between 30 and 60% of the medication. And are done now because of the laws with, not laws, but Lilly and all of the patents, and because supply and demand are back, it's Eli Lilly that is actually supporting a lot of these programs. So just do the research and understand that you are able to have some type of cost relief within this strategy. The key is staying on top of it and understanding how it relates to your own plan. So the questions, I really hope that everybody in this room takes to play and goes home with today are, first and foremost, are you tracking any off-label use? If patients are on them and you're reimbursing them through a program, making sure that your entire ecosystem of benefits knows that you have this plan in place. Otherwise, you truly will not know how your program is working. It also means you want to know every patient on a GLP-1 across the board, because off-label use also includes if a patient is saying type 2 diabetic. The one I saw when I worked at a PBM that came in the most frequently was that they were a precursor, that they look like they could get type 2 diabetes, and was like, no, they don't have type 2 diabetes. We understand you're trying to keep them from getting it, but that would be a denial from a prior auth criteria. So the question you want to make sure is, to your PBM, are you tracking every patient? How are we determining if somebody is off-label? What are the clinical criteria? And how are you maintaining to track the levels and performance of the GLP-1s? The next is, are you being offered real PBM options? And what I mean by that is the word transparent, which was so important to everybody in this room. Kind of understanding, is the PBM's GLP-1 program theirs, or is it run behind the scenes by Optum? One of the things I've seen since coming over to the consulting side is an employer will partner with a transparent pass-through PBM, but some of their cost containment programs are actually being run by the big three behind the scenes. And so it kind of, you can do the right thing on those low-cost medications, but then the minute the high ones come, you want to know who's managing the spend. So these are just things to keep in mind. Next, are you following, and we're going to get into this towards the end, are you following your top 20 claims? And are you looking at what are they trending at? These GLP-1s did essentially come out of nowhere, right? Same thing happened a couple years ago with Humira. Humira had been out for a number of years, and then just enough marketing, it was like the number one drug on everybody's health plan just as recent as 4 years ago. And I joked that, GLP-1s are like the new Humira, but they're not just new, it's more people taking them, than any specialty drug. So it's understanding what are your top 20 claims and what are each individual 20 drugs trend lines. There are software out there that can track that and have the ability to look at what the pricing are just of your top 20 drugs and how it can impact your overall big picture. And so to me, as you're working with consultants in the room, having that kind of a strategy mapped out, and the theme here is, and hopefully you'll hear it over and over again from all of the speakers, renewals don't just happen at the 9-month mark of your plan. They happen the minute claims start to begin to get processed. And it's understanding what are the trends and how you can control them moving forward. So the last piece that I will mention, here is we do not expect any employer here in the room to become the PBM, to make the decisions, and I see again some more nodding and sympathetic nodding, because you're not meant to be the ones in charge of what your patients can and can't access. But where you do have some control, wait, was that 10 seconds or 10 minutes? Because I can talk that fast just to make sure. Okay. I just needed to make sure, But it's understanding that we don't expect HR people to become pharmacists overnight, but more and more now, because those of you here that are HR managers know more about your employees' health than you ever thought you possibly could, and I'm sure a couple years ago you already thought you knew more than you ever wanted to know about your employees' overall health and what they wanted. Now you have to have, if you are telling them no, potentially how they could go about getting them at a lower cost. And so consultants in the room, as you're helping employers, and if they are a company like so many in America today that just cannot afford to do medications that are not truly life-sustaining or part of a traditional benefit plan, have some of those vendors in your pocket that at least HR can say, we don't have it, but here's a way to get it from Canada. Here's some paperwork. Or here's a way you can go directly to Eli Lilly, and this is what we can do. So that they are not just human resources, but they're a resource of information when they have to say no. And that, is kind of where I'm hoping some of you take some of this strategy. I'm going to keep going here because I think I've hammered it. A lot of this, kind of gets into making sure your relationship with your PBM is transparent. That comes at a theme, I think, of every, just looking at the agenda for the next 2 days, everything here is under the expectation that you are going to have good relationships with your pharmacy benefit manager, that they are working with, in the same incentives as you, and that they are aligned in cost containment and access to these medications. Understanding that there are so many strategies, even within the transparent PBM world, that continue to evolve every day. Sitting at my desk, I get calls and LinkedIn messages for more strategies than I ever thought possible because of the need to cost contain. And so exploring those, seeing how open your pharmacy benefit manager is when you do find one of those solutions, whether it's partnering with hospitals that are in your own network. We've heard of the term reference-based pricing. There's also the term reference-based pharmacy pricing. It's a thing. And seeing if local hospitals would work with you, even, getting rid of middlemen to be able to help get cost containment. And everything gets down to PBM contracting. And when we were setting up today, this could be its own hour of a conversation. And again, I'm seeing more nods. PBM contracting is where things get very complicated, but also can clean things up so that you have the ability to audit your pharmacy benefit, understand what clauses are in there and what you can get transparently. And, my favorite tip is not just asking your PBM, how much do you charge us and how much is it going to be, but why? Why do you think this is going to be our cost? What are you basing it on? Do you have trend factors that go into what our group is? And finally, who are all of the players that get paid? Making sure you understand if a PBM is partnering or outsourcing anything. And this can be from cost containment programs to rebates themselves. When anything is passed through, you always want to know, well, somebody else got paid to pass it through. So those are just questions that, I always like to help employers understand. So kind of summing this up so we can get to the end here, just as far as coverage strategy goes, I would make sure you have prior authorizations in place for specialty medication or for GLP-1s. You want to make sure that those prior authorizations are not just based on medical necessity because, again, with obesity, it's kind of, you can find a few different ways to get that claim to go through. But making sure there is strict clinical criteria, as well as, especially with weight loss, a way to get the patient off of those medications and really building in that into your SPD and communicating it with employees. I heard in the previous session, we talk about, one of the hardest things is employees not understanding what the benefit is that's being provided to them. Make sure they understand, right? You would not buy your child a $12,000 toy without telling them how it works. As employers, you are essentially giving your employees $12,000 annual give or take premium toys. You've got to help them understand how it works. And that to me is really so true in the GLP-1 category. I will get, these are all going to be available after so you can get, deeper, but understanding modifications, companies you can work with and ways to build these into your criteria. And finally, this is so important, which is the role of stop loss and reinsurance with any program, especially GLP-1s. Make sure that whatever strategy you do is communicated to your stop loss carrier as a consultant, as the group. Ask questions. Did you make sure they know we're doing X, Y, Z? Because GLP-1s are causing underwriters to really have to spike rates up as a result of this category. So, and the other piece is when you have decided the PBM you're working with and everything feels good, ask the PBM, do you have stop loss carriers that will give points? Do you have a partnership? Because points can come back and rates can go down. It's just another tool. So, where I think we're going here, I don't think GLP-1s are going to slow down. I think this is a hot topic. I think we're going to continue talking about them. And playing with the name of today's presentation, I don't just think it's a tsunami, it's a riptide. I mean, everybody is going to be impacted by GLP-1s. And I mean everybody. We're going to see it in the Medicare space. I mean, it's going to be everywhere. And so you can't outswim it, but you have to learn how to float. They're here, so we have to understand how to do them. If you're interested or you just were wanting some inspiration for questions for our fireside chat coming up, there is a lot of things coming out in the industry. PBMs, again, we're kind of cool, the industry. I mean, we're all over the news. There's PBMs and lawsuits. It's like we could have Bravo has not called, but if they do, we could have some, real housewives of PBMs because there's a lot of things happening, everything from state regulations to picking on the big three PBMs, which that I would do, to misaligned incentives where PBMs own their own pharmacies. What's happening is Americans are waking up. They're understanding that PBMs have manipulated the cost of healthcare for far too long. And PBMs are necessary right now because of how they work from an electronic standpoint and maintain patient safety. But where do we go from here?
Thank you so much. Rachel Strauss. We'll do some Q&A and before our sponsor announcement, and then a DPC panel Q&A. And we've got a lot of good questions, as you would expect with this kind of topic. And when you go into Slido, put your question down, but I also need you guys to click on the ones that you like so that those go to the top, and then I ask the ones that are collectively groupthink, the ones that you want to hear about the most. Okay, so thumbs up the ones that you think are going to be the ones you want to answer the most. Okay, so the first one, the top one is, does self-fund health PBM allow for creativity with GLP-1 coverage like presented? I'm gonna defer that one to our clinical team because they're the ones working through that currently. So come see us afterwards. And I know that's from a lot of the current self-fund health clients here. So what are the negative long-term effects of GLP-1s to the patient? Are people signing up to be guinea pigs and taking these for weight?
So I am not a physician. All I do is read a lot. And anecdotally, I can tell you that, I think that we're going to see some other issues come up as a result of GLP-1s. I don't know if it's going to be dramatic or class action lawsuit or anything like that, but I can tell you we have seen a spike in gallbladder incidents with the population, and again, that's going to be a counteraction to taking the GLP-1s. I think it's too early to tell. I do think that it's going to be, right? I mean, if you think of the law of averages, right? I mean, if you look even at any medication on TV, right? They say very fast in the end, if, this could cause this, and this, right? Well, maybe only a certain percentage of the population takes that medication. So, it might be one patient out of 1,000. Well, when you've got more than 100 million Americans on a GLP-1, those numbers are going to become more increased and as a result, more publicized. So that may cause some deterrent of the overall class, but I don't think they're going to be pulled from the shelves.
All right, here's another one, direct to consumer. That's interesting. Thoughts on companies like Hims and hers, who market themselves as more transparent pricing models for meds that, obviously are the GLP-1s. So, are they transparent? They?
Yes and no. I mean, it's no different than, GoodRx or any other consumer-based patient model where you can look up, the cost of a medication. What they're doing is they are marketing to cash pay. And that is where I get back into all those strategies, right? If anything you see on TV is actual Ozempic, actual Wegovy, not semaglutide, not things that they're doing in med spas that are they're like whack-a-mole because Lilly is drilling down. They're not wanting imported compounds anymore since the supply is back. But, I do think that if you as an employer find a cheaper thing out there, you should figure out why it's not part of your plan, because that is exactly what we're talking about, is that there are lower costing strategies. And if the employer wants to pay for them, find a different mechanism, but get them out of your overall claims so they don't impact your overall renewal.
Awesome. Okay, you mentioned we need PBMs. You said those words for now. You said we need PBMs for now. This is an interesting question, and it's sort of the why. Do we need PBMs? But can an employer just work directly with the manufacturers outside of the PBM? Why do we need that contract in the middle?
Yeah, so I just got a dream project brought to me for a white paper last week. And it was basically a case study where they said, if you had 50,000 lives, what would you do? And you're the employer. You've got all 50 states. How would you build what would you do for the pharmacy strategy? And the question was, would I hire a PBM? I think PBMs are necessary by way of a network, right? A PBM is creating an access channel to pharmacies to be able to adjudicate a claim. So think about your Visa card, right? It's available, you can use it anywhere. And the merchant is swiping the card that is talking to your bank and making sure you have money in it. The PBM is doing essentially the same thing, but instead of money, it's verifying your age, your gender, that you can take that medication, and that you're not taking something from a different pharmacy that could essentially cause a reaction in you to die. So there is a need for these records and a way to process them to be connected. And that is for, we talk about expensive drugs, brands, specialty, GLP-1s is becoming its own animal, but you're only talking, most employers in here or health plans exceed 80% generic utilization by count of drugs. So for every script process, more than 80% of them are a generic medication. 20% of them are brand, and that, by the way, flips because 80% of the cost come from that 20 or less percent of brands. So for the vast majority of Americans, you have to have a network and a way for those medications to be acquired. For brand medications and specialty, I think that could be the future. I think you are going to see more and more direct negotiations with wholesalers who will have the ability to adjudicate and have that same connection like a network. I think we're a little bit away from it. I think that PBMs, especially the big three PBMs, have so much power in this country with the healthcare systems, especially as we keep seeing so much vertical alignment. But yes, I think that if you can find a deal with a direct wholesaler and figure out a way for your PBM to let it run outside the plan, that's the way to go.
And I know there's a lot of, Mark Cuban, right, kind of has a lot of this discussion right now across the country, and a lot of people have no idea what he's actually doing, right? Because he didn't create a PBM. He's partnering with PBMs. He's actually manufacturing.
He's a wholesaler. He's essentially
a lot of drugs, and most of them are the generic medications, which cost 3 cents or less per pill, half a cent per pill. That's why you don't see commercials for lisinopril, right? Because it's $16 for 1,000 pills. You see commercials for, the Skyrizis and the Ask Your Doctor About This, because those drugs are costing employers $10,000, $25,000, $30,000 plus per dose.
Yeah.
Per dose.
What Mark has done is he's, number one, again, he's brought light to the industry. PBM is becoming more and more it used to be my friends thought I was a drug rep, and I would be like, no, I'm not a drug rep. And now they're like, oh, do you do what Mark Cuban does? It's not exactly, but we're getting closer. What he has done is he has basically brought money back to who should be making it, the pharmacist and the people who are selling the drugs. And because the pharmacies, by the way, are not who make money. Most pharmacies, it's super sad. The drugs are a loss leader for them. They are selling at a loss to get you in their store to sell you the shampoo from the other aisle. That's where the markup is. And what Mark Cuban has done is, number one, he's identified that not only are the pharmacies losing money, but the PBMs were adding the price for themselves. And so he created cost plus, which, by the way, is the definition of spread, which used to irritate me, seriously, because I was we're trying to move away from spread. But the spread is going to the right person.
And it's transparent.
And it's transparent.
Yeah.
So Mark Cuban is a strategy. Unfortunately, because his focus is on the generic drugs and that's what he's selling, it's not as highly adopted because people aren't as excited to save, $11 as they need to save $15,000, right? And so I think he's getting more and more into the biosimilars, which are generic specialty. So that'll be interesting in the future.
Okay, a couple of quick hits here before we transition. What's the juiciest PBM insider shell game that you're willing to tell us about? And you're going to be here tomorrow as well, correct?
Yes.
So Rachel's going to be here the whole time.
Happy hour, I would find me, but the one I will say on stage, I just found last week, and that is be very careful with percentage of savings arrangements. I just did an RFP last week where the PBM, and that PBM is not here, so I will say, everybody can relax. Everyone's good here. We're all good people here. No dark side. They had a program in place with a percentage of savings type, specialty arrangement. And I was looking at the invoice, and it was showing an average. It's relevant. It was Ozempic, and it showed the average cost of Ozempic was $2,800. That's not true. Even for cash and not trying, it's about $1,100 maybe, if you're not even trying to find a coupon. Then they showed they imported it. Great strategy if your company's comfortable with it. But the PBM showed it imported it for $800. Well, I know that the importation price is in the $500 ballpark. So that means it was padded, and they padded the number for savings, so they made money on both sides, and the percentage of savings cost that the PBM made for themselves as an admin fee was actually more than if that one drug would have gone through a regular program with a rebate. So it's kind of you just got to be careful, with these percentage of savings and understanding that these PBMs, if that's a profit margin for them in the fiduciary world, that's a buzzword that'll be talked about tomorrow. I think you just have to be careful in understanding what's driving it.
Let's give a hand one more time to Rachel, and we'll move on to our next presentation.
Thank you, guys.